Everyone, and thanks again for being here for a WELS webinar. Tonight's presentation is on pellets, on the preparation and the provision of providing a sterile pellet to your patients. My name's Dr. Campbell, Dr. Tony Campbell, and I work for WELS Pharmacy. I'm a pharmacist here. I've been compounding since 2003. And what I do here is kind of oversee the sterile compounding environment and the personnel, and do many of the formulations and of course webinar and presentations for WELS Pharmacy. So tonight's presentation, like I said, is on the preparation and providing sterile pellets. Tonight's topics, we're going to cover how that's done, what goes into it, the requirements for such things, the differences and advantages of the sterilization techniques, and why you would prefer one over the other. We're going to look at some of the environmental and personnel requirements for compounding, and just take a brief look at the equipment that's used in producing this pellet. We're going to look at considerations, responsibilities, and sourcing on your part on how to find a facility that can provide a quality compounded pellet, things to look for, things to consider, think about, and then lastly, of course, we're going to just touch on some recommendations as far as dosing and lab testing protocols for both male and female patients. So we're going to start off and we're going to talk about ensuring that your pellet that you're getting, that you're putting into this patient, is potent, and how that's done. So pellets have been around since the 1930s. You know, they're kind of growing in popularity, but they're certainly not new. They're used very frequently, you know, over in our European neighbors over there, but in the American market, they're certainly catching on and being used more frequently. So we ensure the potency of a pellet here at the pharmacy by ensuring that our chemicals are of USP or better grade. Of course, there's several categories of drugs. ACS and reagent grade are above USP, so we don't necessarily have to use those. We certainly could, but those are just more costly and raises your costs and our costs. But the lab purified and technical grade of powders we have to stay away from. So we have to use USP powders. So we have a certificate of analysis that comes with each powder or each chemical that we receive. And in those, there's specifications for a chemical to be classified as USP. So as you see, there's a certificate of analysis here. We look at that, and the tests that are done on each chemical are going to vary. This is a particular example of estradiol, mainly because this is a very potent drug, and it's very critical to have your potency as near to what you're prescribing as you can. So you can see here that the assay that they do on this is 97.9% when we receive it. However, you look further down, there's a water content that takes into account also. So all that has to be factored in, and in order to give you a pellet that's the strength that you're thinking that you're giving, there has to be a calculation made. So this powder out of the box is only 94.6% potent. So here in the pharmacy, we have to make special calculations in order to do that, and the pharmacy that you choose should do that as well. And that loss of drying corrections and the potency corrections should be considered for every chemical that you receive. Of course, when you go through all that work to make sure that your calculations are right, you want to have the equipment that you can weigh it right. So the scales and equipment that the pharmacy uses are important. And the suitability of balances is a USP requirement as well in Chapter 41. So you want to have a balance that's able to do at least 4 decimal places, and that is down to the 0.0001. And that's very important when you're making batches that are on pellet machines that are only capable of making 1 up to maybe 6 pellets at a time. Each of those pellets are going to be a very small weight, and if your scale is not sensitive enough to measure it, your potency of your pellet is going to be off, and you're going to get either more or less drug that you're intending to prescribe. So documentation and barcoding software is important for the pharmacy. Be sure that we want to be sure that the pharmacy is scanning, barcoding all their chemicals, make sure they're using the right chemicals. This is all important considerations that as a prescriber that you should consider when choosing a pharmacy. And then of course we want to take into account the thoroughness of mixing this powder. So you're thinking right now, well, What do you mean mixing? It's just estradiol. It's just testosterone. Why would you mix it? Well, in a pellet, there's other things also. There's inactive ingredients. There's lubricants and binders that need to be in that pellet in order to hold it together and in order to make it able to become out of the pellet press. So just as an example, the commercial pellet of testosterone, the 75 milligram testosterone pellet, is more than just 75 milligrams of testosterone. It actually weighs about 77.2 milligrams, and in that there's about 0.25% of stearic acid and then about 2.5% of something called PVP, or polyvinyl pyrrolidone. And that's in there as a binder, and it's also in there as a lubricant. So we see a certificate of analysis also for these inactive ingredients, and this is also important because you can see that in the stearic acid that we have here, the assay only has to be more than 40%. The other remainder of this powder is something called palmitic acid. The difference between these two values, if I were to use the top one initially, as you can see, this was a couple years ago, and then later in the year we got one with a different lot number. The difference in the assay is only about 5%, but as you can see, it's about a 10% difference. So if I'm in my formula, I need a specific percentage of stearic acid. It's important to have these calculations that are done correctly. Otherwise, I have too much stearic acid, and if I have too much stearic acid, I'm going to waterproof that pellet, and the release rate is going to be changed. Stearic acid is derived from edible fat sources. It's widely used in many pharmaceutical products, mostly tablets and capsules. It's also used in a lot of cosmetic products, and it's non-toxic and non-irritant, according to the Drug Handbook of Pharmaceutical Excipients. The concentration and compression force factors are important. We want to make sure that we're using the right amount of stearic acid, not too much, not too little, and that we don't press it too hard, as compression ratio of these pellets will delay the release rate to some extent. The speed at which these powders are mixed are also important. The particle size of the API, the particle size of the inactive ingredients are all important. As you increase the particle size, you increase the rate of dissolution. As you increase the drug load, you're going to increase the rate of dissolution also. And so those are all important factors to consider. Probably not anything that you're thinking of as a physician, but these are all things that you should be considering when you choose your pharmacy, that these are things that this pharmacy, these are the things that they're thinking of and that they're taking into consideration in providing you a pellet that you're ultimately going to be implanting in somebody. So these are all very important factors. So now that we have this pellet, we've gone through all the work of making the calculations. We've mixed it thoroughly. We've got the inactive ingredients. We've got it all done. We still have to sterilize it. So many ways that we sterilize things in the pharmaceutical world is through filtration. Of course, we can't filter a pellet. We can autoclave it. Many pharmacies will autoclave pellets, which is inappropriate because autoclave is by steam sterilization. So your pellet would have to be exposed to steam in order to have it sterilized. Now, many pharmacies will put a pellet in a vial and put that vial in the autoclave, and in effect, they're kind of dry heat sterilizing it. But you can't do that a lot of times because the melting point of the drug, in order to dry heat sterilize, is about 160 degrees for 2 to 3 hours. So the melting point of testosterone is about 155 degrees. So if you do that, you can't dry heat sterilize. You're going to pretty much deactivate your pellet. Or you could expose it to gaseous chemicals such as nitrogen dioxide, ozone, ethylene oxide, those things. And those things have a lot of, they're highly explosive. A lot of them, they have a lot of residual toxicity after their exposure. So the other option is gamma irradiation. So this is a form of electromagnetic radiation, kind of like X-rays, but it's a much higher energy and has a much deeper penetrating power. There's no heat, there's no moisture generated in this process, and there's no residual radioactivity after irradiation. So this is accomplished by exposing it to what they call kilograys in the way that they measure radiation. So at least 25 kilograys would be sufficient for any product that's exposed to that they can do something called parametric release or dosimetric release, which allows it to be released into circulation without having to do a sterility test. So if you can show that the product was exposed to this many kilograms, then you can release it without potency tests. Now there are a couple states that still do require that. I know at least California still requires sterility tests, even though it's been exposed to this type of radiation. So just to get an idea of what 25 kilograms is, I kind of worked out the math on that for you. It comes to about 250 million chest x-rays all at once. So that kind of gives you a good idea how strong this radiation is. The other option, this is a gamma radiation facility. So as you can see, it's very large, very complex. It's a very large building. It's got a lot of moving parts in it. Very, very expensive. The other form that you can do of a radiation is electron beam radiation. This is a lot more compact, smaller, more highly controlled. You can turn it on, you can turn it off. The radiation stops as soon as you turn off the switch. So it's a lot more precise. It also does not generate heat or moisture. And it's the method of choice for processing these high volume and low value, or low volume and high volume products. And this is the kind of example of a facility. This is inside of a building. This is the equipment. It goes in one side, it gets exposed to electron beam radiation, and comes out the other, all sterile. So when you're comparing gamma and electron beam radiation, they're identical in many ways. They both have parametric release. They destroy the bacteria by the same way. They're both governed by the same ISO standards. Both are proven and accepted worldwide, but there are some differences, right? Apples and oranges are both fruit. However, there are some differences. And those differences relate to penetration, dose rate, processing time, material effects, the packaging that they're in, and then the environmental and the cost that's affiliated with that, which ultimately affects the cost that, that you pay for your pellets. So very, very briefly, penetration. Gamma radiation does penetrate further and deeper. Electron beam radiation does the same thing that gamma radiation does. It collides with electrons, kills the bacteria in the same way. The dose rate and processing time. The biggest thing here is that gamma radiation has longer cycle times. So in order to sterilize something, it would have to be exposed anywhere from 6 to 10 hours, depending on the batch size and how thick the material is that it's in. E-beam radiation is 1 to 2 minutes. The effects that it has on the materials that they're packaged in, E-beam is greater in this regard as compared to gamma irradiation, and that mostly has to do with the dwell time that the material is exposed to. So during that time, ozone and heat can accumulate, although we know that gamma radiation is not a heat-generating form of sterilization. The short dwell time with the E-beam doesn't expose the materials to it very long. It doesn't have a chance to oxidize, so you don't have a lot of oxidative damage due to the effects of exposing it to the radiation. And then lastly, of course, the environmental and cost issue. So there's it's a higher containment and processing cost, right, to build a facility for gamma irradiation. Electron beam is very, very minimal cost, anywhere from $50 to $150 an hour to process this. That's the cost on that. So we get right down to the heart of it. All right, so we got the environmental requirements for sterile compounding as a 503A. I'm going to touch on some 503A versus 503B differences in just a minute, but right now we're just strictly talking about a regular 503A pharmacy. So this is governed by USP, Chapter 797, and all pharmacies operating in 503A have to adhere to this code. Most states have adopted this as law, so the pharmacies have to follow this. So if you're not familiar with USP, it's a non-governmental scientific body that's responsible for setting standards for drug quality. It references FDA references and mandates USP standards for compounding. And these were first recognized in the FDA EMA of 1997. It states that a compounder must use bulk and drug substances that comply with the standards of USP or NF, National Formulary Products. In 2013, the Drug Quality and Security Act further clarified FDA's authority over drug compounding and reaffirmed the role of USP under Section 503A. FDA guidance states that preparations compounded by a physician or pharmacist qualify for exemption from an NDA or a new drug application if they're compounded in compliance with USP, and it specifically references both 797 for sterile compounding and 795 for non-sterile. So the objective of 797 is to describe conditions and practices to prevent harm from microbial contamination, excessive bacterial endotoxins, any variability in strength, unintended chemical physical contaminants, and ingredients of inappropriate quality. Now the USP chapters that are below 1,000 are enforceable by the FDA. The chapters over 1,000 are there for to provide information, to give definition, or to define a subject. And they're not really anything that can be enforced, but they're certainly there to be referred to. So furthermore, in the environment of 797, when you can compare this a little bit to the CGMP requirements of 503B. So in the clean rooms, there's things that we call, they're ISO 5, ISO 7, ISO 8, those kinds of things, where ISO 5 is your most clean area, ISO 7 is your clean room, and ISO 8 is maybe your prep area. So anything that's compounded has to be compounded in a minimum of an ISO 8. There's personnel and garbing requirements and gloving requirements prior to and during the aseptic compounding. There's particles that can be generated that are larger than 0.3 microns. The limit for these ISO designations are particles greater than 0.5. So in a slow walk, if you're just wearing a smock, or if the techs in your pharmacy only wear a smock, you're generating 5 million particles greater than 0.3 microns per minute. If you're wearing coveralls, as you can see in the picture in the upper right, you certainly decrease that at 500 particles per minute. So your pharmacy staff is well advised to be wearing these coveralls, as they do generate significantly less particles. So people generally release around 1,000 particles per hour and 40 colony forming units of viable organisms. So even a properly gowned worker will generate 10 to 100 CFUs per hour. So even the best classified environments with people in that environment aren't going to approach what, sterility or the absence of anything growing. So when when you're investigating your pharmacy or looking at you shouldn't be surprised to discover that they have at least 1 or 2 CFUs that are in some of their testing. The the personnel training and evaluation aseptic manipulations, these things are done according to 797. They're required to be done every 6 months. The gowning, fingertip, and media fills, these continually go on. They should always go on, and to be trained, they shouldn't be just done once and then completed. And this is where it gets a little bit more technical, because the environmental quality specifications of 797 require that you do this air and surface sampling every 6 months. But I'm here to tell you, working in a 503A pharmacy, the every 6 months doesn't fly too well when the FDA comes to inspect. So I can tell you from personal experience that we do the air and surface sampling every 30 days here. Now, the testing that goes on for every batch is done with every single product. So every batch that we make, if we make 6 batches in a day, then every single batch will have its own surface and glove and fingertip sampling being done on those. And those are being more and more enforced by the FDA and by the various boards of pharmacy. So it won't be long before there's going to be any 503A sterile compounding going to be done. I would fathom to guess within 3 to 5 years, it's going to be kind kind of phased out. So the routine and scheduled disinfection of gloves and surfaces of ISO Class 5 sources, those should be routinely done every 30 minutes, wiped down in between batches, and certainly those are things you want to look for. And then just furthermore, comparing 503A and 503B, if you're on the fence between choosing a 503A or choosing a 503B because it's a lot more easy for you to prescribe that way, some of the differences here I just highlighted. The environmental monitoring in a 503B is required to be done per shift. So right now as a 503A, we're doing environmental monitoring in our 503A facility every 30 days. So in our 503B pharmacy, we have to do those per shift, so it's going to be once or twice a day. The quality department in a 503A can just simply be a pharmacist. In a 503B, it has to be an autonomous quality department. And really the biggest difference between 503A and 503B as far as it concerns the prescribers is your ability to write for office use. And that's kind of where it becomes convenient for you, that you can order multiple pellets without having to have patient names and separate prescriptions for each one. So this is a little bit on the equipment that we have for pellets. So there's multiple tools that we have. We can have a single, or what we call, maybe you have a single punch with one head on it, maybe two or three. These are manual, and these are compression punches that have to be done physically by a technician who has enough arm strength to pull this punch down and press this powder. This is really not the best way to do it. Smaller pharmacies we have done this. I recall making pellets myself like this maybe 12 years ago, and it's very difficult when you're getting and you're making 100 or 200 pellets. I tell you, after the 110th pellet, your shoulder and your elbow kind of gets wore out. So there's going to be some variability and some compression. So your pellets may not always be consistent. So I really don't recommend that. If your pharmacy uses that and you're having good results, that's fine. There's other pellets machines out here. This one's a hydraulic one. You still have to compress it by hand, but you do have the ability to conceive the compression force, and it's a lot more consistent. So you have your pellets are more consistent from pellet to pellet. There's other ones that are fully programmable, and you really just have to weigh the powder in there and then push go, and there's no manual labor involved in that whatsoever. So when it comes to thinking about things, if you're new to this and you're trying to find a pharmacy, you know, where do you start? What kinds of things do you look for? The Pharmacy Compounding Accreditation Board was something that was around maybe 10 years ago, and they say on there that based on USP convention standards that it offers the most comprehensive compliance solution in the industry. Well, that may be true, but it doesn't necessarily guarantee that you're going to get a quality product. It only shows that they have fully complied with the standards of PCAB. In 2014, PCAB became a service of the ACHC, and what that basically does is the surveyors will come out, they'll give some recommendations, they'll have 6 months to make those changes, they'll come by with an unannounced survey, and then once that's done, they'll go through a plan of correction, and if it's accepted, then they get fully accredited. So these are, most recently when I looked, there's upwards of 462 accredited pharmacies in all 50 states. So if this is important to you, you should be able to find a PCAB accredited pharmacy pretty easily. However, not all those pharmacies will do sterile products. So this includes pharmacies that only do non-sterile. So if you're looking for this, you might be hard pressed to find a pharmacy that's PCAB accredited that also does sterile. So some of the other things that you look for in place of that are some things here that are some of the basic laws at minimum. These 503A pharmacies, that they're going to only compound from a valid physician-client-patient relationship. So you're not going to, these pharmacies aren't going to fill 50 to 100 pellets for you with one patient name, right? You have to have a client relationship with each patient. They're not going to compound commercially available products, so if they're compounding 75 milligram pellets for you at a reduced cost, they know that's not anything that we're going to do, but we'll provide you with an option or an alternative. They're licensed in all the states. They don't compound products for the purpose of resale if they're a 503A, and they maintain a clean room that exceeds or meets at least the USP 797 standards if they're 503A. So these are at minimum some of the things to think about when you're looking at a pharmacy. Ultimately, what it comes down to is you doing the homework and knowing that you have a pharmacy that has a knowledgeable and experienced compounding pharmacist there and staff that's able to help guide you, you know, with maybe some dosing recommendations or problem-solving skills. You know, it's great to have a CEO and business managers. Those guys are key and instrumental in getting the business going and getting the market. But when it comes to problems, that all comes back down to the pharmacist when there's formulation issues. So it's important to have somebody on staff like that at your pharmacy. Even more than that, the technicians are the ones who are most of the time doing the manual work on this. So you want to have be sure your pharmacy has competent technicians that work with integrity and ethical behavior. Somebody that you can trust, techs that are motivated, they're competent. You want to be able to develop an honest working relationship with the pharmacy staff. So what this means is that everything's running smooth, but there's going to be times where there's unforeseen issues that are going to arise. You're going to have a problem with a pellet. You're going to have maybe something, a pellet that might extrude, and you're going to blame the pharmacy for that. But you got to keep in mind that there's a lot of factors that go into play in that. Or maybe you didn't get it in time, or maybe they're back ordered. So you don't just cut and run, cut ties and run, and you abandon it and go to the next pharmacy. Because what you're doing is creating inconsistency with your patient. So you want to maintain that consistency, of course, as long as you can, until you just can't tolerate it anymore. Then maybe it's time to jump ship. So the pharmacy has to be able to provide quality and timely service to you and your patients, make sure that they get you what you need when you want it, and they're able to do that consistently. And as you grow, they're able to keep up with you as you grow. Hopefully your business is growing, and hopefully the pharmacy can keep up with your needs as well. And the very last thing I put on here for considerations for choosing a pharmacy or a source for your pellets is price. It really should be the last thing that you're concerned about. You know, any pharmacy can undercut any other pharmacy, but what you're really looking for is a quality pellet, because you're putting this in somebody's body. So you always don't want to go with just the cheapest thing. Right? If the best pellet is the cheapest, fantastic, it's a win-win. But you don't want to just cut to the lowest price and say this is good enough for my patients. There's going to be some sacrifice there. So all those things we discussed in the first few slides should all be things that that the pharmacy that you choose considers, and those are very important things to consider, because it's going to affect release rate, it's going to affect your patient's testosterone levels, it's going to affect a lot of things that go into play in that. And when it doesn't work out, you certainly don't want to be blaming the pharmacy. You should be blaming yourself for choosing the cheapest pellet you could find. You certainly don't go to the store and purposely look for the cheapest shirt or the cheapest pair of shoes, or that you don't purposely buy the cheapest car that you can find. Right? You want quality product that's going to last, that's going to have a good effect, it's going to be backed up by by quality, it's going to have a it's going to work out with your problems. So this is, again, just driving it home. Price really is the last thing to consider. So we're going to get right to the dosing options. I'm going to start with the females. All right, so the first thing you want to do is get some recommended baseline tests, and these are just minimum recommendations baseline tests. These aren't all inclusive, but these are some of the minimum ones that you should get. The lipid, metabolic, and thyroid panel. Now the testosterone pellets aren't necessarily going to have any effect on these, but it's good to have for patients that are new to you to find other disease states that they may be prone to. So if you've got a good clinical picture of the patient, rather than just some hormone testing levels, I think that's beneficial for the patient as well. Maybe some C-reactive protein, and then your HbA1c levels. And then, of course, you want to do your full hormone panel. So that would include estrogen, progesterone, testosterone, DHEA, and cortisol level. Then your follow-up test is going to be about 8 weeks after insertion of the pellet. And in women, you're going to implant those pellets about every 3 months. You want to get a free and total testosterone. You want to see what's being bound by sex hormone binding globulin. There's a lot of testosterone that's bound to that. So I think it's roughly about 98% is bound to that. So when you're getting your free levels, it's important to know. That's very, very important. You know, if you get a total testosterone, you also want to get estradiol levels to see if your patients are aromatizing your testosterone to estrogen. And then the progesterone, you just want to get just so you can get an estrogen to progesterone ratio. You're not looking to treat progesterone levels with a testosterone pellet, of course, but it does give you a good idea on if they're aromatizing. The optional ones are thyroid, lipid, follow up with your HbA1c, and then test every 3 months until these patients are balanced, and then you can reduce that test every 6 months. Ultimately, what you want to do is have 4 insertions and 2 lab reviews annually, and this is kind of what you're shooting for to get your patients up to speed there. So in women, the pellets will last anywhere you'll find from maybe 2.5 at the least. So usually 3 to 5 months in women. So you want to be doing these about every 3 months in females. Some recommended dosing options. A lot of these are found in the literature. These are weight-based female testosterone dosing options. You can look at that and read that for yourself there. So the doses ranging from 50 to 225 has been used very commonly throughout the medical literature. In the U.S., what we find is most doses used in practice or in real life range anywhere from 100 to 160 milligrams. So you're going to find with these patients, you're going to have testosterone are going to decrease any depression, anxiety your patients have. They'll increase bone density, muscle mass, energy, of course, sense of well-being. You're going to increase sex drive, libido, anything that your patient is complaining about in those regards. Testosterone pellets have been found in many studies to show that this is proven to be very effective. So after 1 month, when you test your patient, you're going to be looking for levels generally from 150 to 400, depending on how many pellets that you're implanting. The symptoms that these patients have are generally found to return when their serum levels reduce to the upper limits of normal, which is in most literature you'll find it's around 70 to 120 maybe. The normal range for women, of course, is, depending on where you read, it's anywhere from 15 to 70. Some other sources might be a little bit less than that, so 10 to 50, and in postmenopausal women as little as 2 to 40. But it really depends on the testing facility that you're using or what literature that you're reading at the time. I found a wide number of reference ranges in women, so there's really no standardized reference range that you look for, and ultimately what you're not wanting to do is just get that patient within that number, because you're not treating a number deficiency, right? You're treating a hormone deficiency, so you want to treat the patient's symptoms ultimately. So we get to the male. So again, some of the recommended baseline tests, again, the lipid, metabolic, thyroid panels, all the typical ones, your luteinizing hormone, prolactin, and your PSA in men. Of course, you want to get estradiol initially, and then your testosterone, your total and free, and then again, a baseline sex hormone binding globulin. These follow-up tests is going to be 3 months after insertion to implant every 4 months. You want to test your testosterone, total and free again, as well as your sex hormone binding globulin. You want to test PSA prior to each insertion for at least 2 years while you're doing this to see if there's any increase or rise. Estradiol levels is important to see if they're aromatizing. Again, you want to test every 3 months until they're balanced, and then every 6 months after that. In men, you want to do a 3-3 protocol, so you're going to do 3 insertions and then 3 lab reviews annually. So you're going to be doing this a little bit more frequently in men. So the pellets in men, it lasts about 4 to 6 months each time you're going to do this. So it's really going to depend on the person. So the release rate on a pellet, if you're interested, is generally found to be about 0.5 milligram per day per pellet. The physiologic release rate of testosterone is found to be about 6 to 9 milligrams a day. So if you're inserting 12 pellets, you're going to get about 6 milligrams a day of testosterone. So the peak levels after insertion are usually seen after a month. You want to shoot to be in the neighborhood of 800 to 1100 nanograms per deciliter. After 4 to 5 months, your levels are typically going to decline between 500 and 600, but you're going to be doing some reinsertion at that point. So the PSA testing. So if your PSA initially is less than 1, you can go ahead and it's recommended to use pellets. When you do your PSA testing initially and it's more than 1, it's recommended to do IM testosterone or topical testosterone. And then retest after 3 months. If it doesn't raise, you can use pellets. If it does increase, you want to consult a urologist to see to do further testing. So after, if it goes from 1 to 2.5 after 3 years, if it stays within that range during that initial testing, it's okay to use the pellets. If they have a history of your PSA being tested and it's been within that range for 3 years, pellets is okay. If it's above 2.5 with prior negative biopsy or a urologist clears it, then pellets would be okay in that regard too. So those are just some things to keep in mind when you're prescribing pellets for your male patients. So some dosing options or recommendations. So the testosterone levels in men do vary significantly. So they can have a great difference. They can vary from 200 to 500 points over the course of 24 hours. So in many of the studies that you'll find in the literature, 50% of the patients will have a much higher AM testosterone level, and then the other half will have higher PM levels. So when you're doing your testing, you want to be sure that you're doing consistent time. So don't do blood testing for testosterone in the morning one time, and the next time, draw it at 3 or 4 in the afternoon, because they're going to be significantly different, and you're not going to have consistent numbers. So in total pellet dosing, so most studies performed in the literature, they use anywhere from 6 to 1200 milligrams. Therapeutically in the U.S., the most commonly seen dosages are anywhere from 8, 9, up to 1200 milligrams. In your larger men, you're going to probably use a little bit more, and 1400 to 1600 pellets, so 7 to 8 pellets of the 200 milligrams in your larger men. So you want to check the estradiol levels, right? If the patient is complaining that they don't feel anything, or they get complaints of their anxiety or aggression, which is very uncommon, but in some cases that does occur, or patients will say that they feel anxious about things. So typically your dose is a little bit too high for them, or they're just metabolizing that very slowly. So if indicated, consider the addition of anastrozole. So you can give this orally, 0.5 milligram twice a week, or alternatively, you could include it in a pellet. I know we provide those testosterone and anastrozole combinations as well. So in those patients that have very high estradiol levels initially, it might not be a bad idea to begin that either orally to begin with, or include it in your pellet. So the goal of these testosterone pellets is to restore testosterone to the upper limits of normal for a young man, which is anywhere from 900 to 1100. And you're going to see those levels after about 30 days after implantation. Your goal is to keep it above 600, but you want to keep in mind that patients are going to be very variable in their response to this. So, and their symptoms may return when your number is a little bit higher, or they may have good symptom control when their levels are even below 600. So you really want to take all things into consider and not draw too much focus and attention strictly on a number. So the benefits of testosterone pellets. So there's a lot of literature research on this. You can see at the bottom that I've included a lot of studies on there. There's even more than that, but really testosterone delivered by implantation is known to, it bypasses the liver. It does not affect clotting factors, does not increase the risk of thrombosis or breast cancer. It is cardioprotective, and it doesn't have any adverse effect on blood pressure, lipids, glucose, or liver function. These other benefits that we see, I'm not going to read through all of these, but you can see there's a number of proven benefits in the medical literature of using testosterone pellets, and these are both in male and female. The thing I just really want to draw your attention to is the last one. So a low incidence of localized allergic reactions. So patients or physicians, either one who prefer the commercial product, keep in mind that that product does have PVP in it as a binding agent. And you might get some sensitivity reactions with that in some patients. So, treating that can be, often they've done studies on this, and they found that a site reaction to this commercial product is often related to low cortisol. So what they recommend is using Benadryl, 25 to 50 milligrams every 6 hours as needed. Draw some AM and PM cortisol levels. Look at their symptoms of high cortisol, and then if indicated, begin hydrocortisone. If they don't have a response to that, it's recommended to go to a Medrol dose pack. But don't remove the implants. You want to look for signs of infection. If they do have one, of course, begin Keflex. But then the pellets, next time you implant, be sure you get one compounded without the PVP in there. So I've had a lot of physicians do that, and they've come and then they get a compounded pellet, and some of the patients will still have a site reaction, and they'll want to know what else is in this pellet, and we'll tell them the only thing in the pellet, of course, is testosterone, but then we also have stearic acid in some of those. So they ultimately think, well, my patient's having a sensitivity reaction to stearic acid. That's generally not the case, but if you do want to try something else, we do offer a testosterone with no stearic acid, and the other ingredient that we use is straight cholesterol as a binding agent, and it also acts as a lubricant of sorts. So that's another option as a compounded pellet product, is to have it compounded with stearic acid and or cholesterol. So just wrapping up here, I do want to leave time for some questions, but be sure you're getting quality chemical suppliers that are FDA registered. They get certificates of analysis. They're using USP ingredients. Make sure that the pharmacy is able to produce accurate weights. Make sure that they're sterilizing their things properly. The compounding environment and the personnel is trained, they're educated. The environment that they're making their pellets in is acceptable and up to standards. That they have the equipment to provide a consistent and quality pellet, right? They're not pressing these things by hand. And lastly, right, we want to take personal ownership. So take it upon yourself, right? You have a responsibility to your patients to make sure that you're providing them and inserting in them a quality product. So do your research, request documentation from the pharmacy, ask for the potency results, ask for the sterilization results, those things. And if you're able to, of course, just visit the facility as well. Get to know the pharmacist, get to know the staff, get to know where you're getting these products from that you're implanting in your patients. So with that, I just want to turn it over just to Jen real quick, and she's going to talk about this upcoming conference here that we're having regarding pellet therapy.
Thank you,
Jen?
Tony.
Yep.
So my name is Jen. I'm the marketing manager at w0hhl Pharmacy. So while we have some questions coming in, I did just want to let everyone know that Tony, as well as Dr. Orbeck, will be doing a 2-day intensive session on pellet therapy. It will be hands-on. There is a $200 savings for you guys if you're interested with the code w0hhl17. So if you want to sign up for that, it's going to be in West Palm Beach, Florida, Friday, July 28th and Saturday, July 29th. So we do encourage you to do that. So we have a few questions that have come in, Tony. So let me start reading some off to you. One person is wondering, what is the dosing recommendations do you have for anastrozole and the testosterone pellets, and what is the goal for the male estradiol levels?
Right. So typically, in the if you're looking to do a testosterone and anastrozole pellet, a lot of that research was done, and a lot of doses on that are your typical dose of testosterone, which is going to vary by your patient. But say you're using 200 milligrams testosterone, so your dose of anastrozole typically is generally in the neighborhood from 6 to maybe 8 milligrams, sometimes as little as 4 milligrams. It really depends on the patient's estradiol levels. So normal, men's normal estradiol levels, what's normal for one patient, that they're able to function without side effects could be different, but there's certainly some reference ranges, I think, just available publicly for estradiol levels in men. I don't have any, in front of me now, but if you want to email it, that to me, I can certainly find that for you and give you a range of what you should be looking for estradiol in men. But typically in the pellet, we find that I'll just say in about 6 milligrams would be sufficient for most patients if you're going to combine it in a pellet. But it does vary from 4 maybe to 8 milligrams.
Okay, and I do just want to let people know, I know people are wondering, this webinar will be available, the recording as well as the slides after this. We'll go ahead and email it out to you guys tomorrow, so you will get a copy of it, so don't worry if you didn't make it to the whole webinar. Now, Tony, someone wants to know, what companies are sterilizing testosterone pellets?
What companies are sterilizing these pellets?
Yes.
There's a couple that we've used. I know I can't recall the name of the company that we use at the moment. Our quality department I know has that, but I can certainly get you that information if you're interested in knowing who we use. That's certainly something that's easily, I could email you that tomorrow morning.
Now, I'll give it another minute for some questions to come in. If anyone else wants to ask Tony a question, you can go ahead and submit it through the question or chat section. And any information that you guys are looking for, you can go ahead and email myself, jgomez@w0hhl1e.com, and I can triage any questions to Tony, and he can get anything answered to you guys. And I guess if we have no other questions, we're going to go ahead and wrap this up. And like I said, you guys will get a copy of the recording and the slides tomorrow, so hopefully you enjoyed the webinar. And Tony, thank you so much.
Okay, thank you all.
Bye.
Bye.